नमस्ते बिटिया, हमेशा खुश रहो बिटिया। Myself Dr. Arti, JAYOTI VIDYAPEETH Women's University. Our today's topic is thyroiditis. What is thyroiditis? The inflammation of the thyroid. Thyroiditis is more often due to non-infectious causes and it is classified on the basis of onset and duration of the disease into acute, subacute and chronic. This is the term Hashimoto thyroiditis. It is an autoimmune and chronic lymphocytic type. Hashimoto's thyroiditis, also called diffuse lymphocytic thyroiditis, strumolymphomatosa, or goitrous autoimmune thyroiditis, is characterized by three principal features. First is the diffuse goitrous enlargement of the thyroid, lymphocytic infiltration of the thyroid gland, and occurrence of thyroid and autoantibodies. Hashimoto's thyroiditis occurs more frequently between the age of 30 and 50 years and shows an approximately 10-fold preponderance among females. Hashimoto's thyroiditis is the most common cause of goitrous hypothyroidism in regions where iodine supplies are adequate. The regions where iodine intake is more have higher incidence of Hashimoto's thyroiditis, that is in Japan and United States. Etiopathogenesis, autoimmune pathogenesis of Hashimoto's thyroiditis is explained by the following observations. First, other autoimmune disease association. Like in many autoimmune diseases, Hashimoto's disease has been found in associated with other autoimmune diseases such as Graves' disease, systemic lupus erythematosus, SLE, Sézary syndrome, rheumatoid arthritis, pernicious anemia, and type 1 diabetes mellitus. Second, immune destruction of thyroid cell. An association of cytotoxic lymphocyte-associated antigen 4, CTLA4, a T cell regulatory gene, with autoimmune phenomenon in Hashimoto's disease has been reported. There is initial activation of CD4 plus T helper cells, which then induce infiltration of CD8 and T cytotoxic cells in the thyroid parenchyma. Now the detection of autoantibodies. The following autoantibodies against different thyroid cell antigens are detected. First is the thyroid microsomal autoantibodies against the microsomes of the follicular cells, thyroglobulin autoantibody, and TSH receptor autoantibody. 4. Inhibitory TSH receptor antibody. The TSH receptor antibody seen on the surface of the thyroid cell in Hashimoto's thyroiditis is inhibitory of TSH, producing hypothyroidism. Similar antibody is observed in Graves' disease, where it causes the hyperthyroidism. It appears that TSH receptor antibody may act both to depress or stimulate the thyroid cell to produce hypo and hyperthyroidism respectively. Now the genetic basis includes the disease has higher incidence in the first degree relative of affected patient. Hashimoto's thyroiditis is seen more often with HLA-DR3 and HLA-DR5 subtype. On general examination, the classic form is characterized by diffuse symmetric film and rubbery enlargement of the thyroid, which may weigh 100 to 300 grams. Sectioned surface of the thyroid is splashy with accentuation of normal lobulation but with retained normal shape of the gland. The fibrosing variant has a film enlarged thyroid with compression of the surrounding tissues. Microscopic examination, the classic form shows following features. There is extensive infiltration of the gland by lymphocyte, plasma cell, immunoblast, macrophages with formation of lymphoid follicle having germinal centers. There is decreased number of thyroid follicles which are generally atrophic and are often devoid of colloid. The follicular epithelial cells are transformed into their degenerative state termed Hurthy cell, also called the Eskenazi cell and oxyphil cell or oncocytes. There is slight fibrous thickening of the septa separating the thyroid lobule. The less common fibrosina variant of Hashimoto's thyroiditis shows considerable fibrous replacement of thyroid parenchyma and a less prominent lymphoid infiltrate. The clinical features include the presenting feature of Hashimoto thyroiditis is a painless, firm, moderate goitrous enlargement of the thyroid gland, usually associated with hypothyroidism in a middle-aged woman. At this stage, serum T3 and T4 levels are decreased and RAIU is also reduced. A few cases, however, develop hyperthyroidism termed Hashimotoxicosis, further substantiating the similarities in the autoimmune phenomena between Hashimoto's thyroiditis and Graves' thyrotoxicosis. Now there is another term called the subacute granulomatous thyroiditis, decurvens thyroiditis. The granulomatous thyroiditis, also called the decurvens or subacute or giant cell thyroiditis. It is a distinctive form of self-limited inflammation of the thyroid gland. The etiology of condition is not known, but clinical features of the prodromal phase and preceding respiratory infection suggest a possible viral etiology. The disease is more common in young and middle-aged women and may present clinically with painful moderate thyroid enlargement with fever, features of hyperthyroidism in the early phase of the disease, and hypothyroidism if the damage to the thyroid gland is extensive. General examinations show there is moderate enlargement of the gland which is often asymmetric or focal. The cut section of the involved area is firm and yellowish white. Microscopic examinations show initially there is an acute inflammatory destruction of the thyroid parenchyma, formation of microabscess, and later the more characteristic feature of granulomatous appearance is produced. These granulomas consist of central colloid material surrounded by histiocyte and scattered multinucleate giant cell. The more advanced cases may show fibroblastic proliferation. Now next one is the Reeder's thyroiditis. The Reeder's thyroiditis, also known as Reeder's tumor and invasive fibrous thyroiditis, it is a rare chronic disease characterized by stony hard thyroid that is densely adherent to the adjacent structures in the neck. The condition is clinically significant due to compressive clinical features like dysphagia, dyspnea, recurrent laryngeal nerve paralysis, and stridor, and resemblance with thyroid cancer. The etiology is unknown, but the possible Reeder's thyroiditis is a part of multifocal idiopathic fibrosclerosis. General features include the thyroid gland is usually contracted, stony hard, asymmetric, firmly adherent to adjacent structure. Cut section is hard, devoid of lobulation. Microscopic examinations show there is extensive fibrocollagenous replacement, marked atrophy of the thyroid parenchyma, focally scattered lymphocytic infiltration, and invasion of the adjacent muscle tissue by the process. This is my reference. I hope you all enjoy this session. If you have any query, please mention it in comment box. Thank you.